Hey everyone, welcome to Taking the Pulse, a healthcare and life sciences video podcast. I am Heather Hoops Matthews here in the studio, and joining me is Lauren Moss. She is a healthcare lawyer with Maynard Nexsen. Lauren, great to be with you.
Thanks so much, Heather. Great to be here.
Also joining us is Pat Hymel. He is a physician entrepreneur and the CEO and co-founder of Indicator Sciences, a company dedicated to enhancing inpatient nursing performance, patient outcomes, and opioid safety through innovative analytic services like CareFX. Dr. Hymel, thank you so much for joining us today.
Thank you for having me, Heather.
Will you begin by just telling us a little bit about your background in the healthcare industry?
Sure. I'm an emergency medicine residency trained physician, and really enjoyed clinical medicine and intended on being a bedside practitioner for years and years. Sometime during residency, however, I began doing AI research back in the late 90s, early 2000s with a good friend here in Birmingham at the UAB. And that research turned into an AI system for identifying outbreaks of infection in hospitals. And we put on our entrepreneur caps and started a business together during residency, which I can't recommend, and grew that business to 200 hospitals or so. A real consultative analytic company, software as a service. But our hallmark was that we would identify problems, but then really work to help the customer solve them. So the analytics pointed the way, but the service delivered the customer what they were really looking for. So that company was acquired by a Fortune 20 company, by Cardinal Health. And since that time, we've continued to be involved in advanced analytics and healthcare quality. One of the things that we learned from that business and growing it was that, technology, as I said, gets you part of the way there towards quality, but it's the human interaction and the human understanding of the analytics that causes them to make better choices or improve a process. That's the deliverable of the analytics system. So,
Dr. Hymel, tell us a little more about CareFX in particular and how that idea came about.
Yeah, so after we finished up, MedMind eventually grew to over 600 hospitals across the United States and even beyond. And so that was a fantastic experience, but there was a leftover problem that we weren't able to solve. And so MedMind used what today would seem to be a primitive form of AI to identify a unit in a hospital that has a problem of a particular type of infection prevention technique or process. And so we would send educators to 3 West or the MICU and say, improve the following processes to improve the infection risk of the patients. And so they would do this, but an MICU is staffed by at least 4 different shifts of nurses who all have to be educated and in service. So these were big lifts for the unit manager and the educators to do. And then we'd come back the next month, run the analysis again, and sometimes they didn't get better. And so you go back to the unit manager, and the unit manager would almost always say, look, I know that 95% of the people that I've given this training to and given the in-service are doing the right thing. Tell me the 5% of people who are not doing it correctly so that I can just focus my education resources on those people. At the time, 10 years ago, can't help you. There's just far too much variability in terms of the patient, in the context of care around the patient, care plans, physician input, ancillary stuff. I mean, it goes on as to the variability of the patient and their environment. And then you have to try to understand how an individual nurse may be contributing to something like infection risk. Very, very difficult problem to solve. If you try to solve it, you go talk to the individual, you go talk to the individual nurse, typically you'll hear things like, my patients are sicker. And sometimes they're absolutely right. Their patients are sicker. And so this challenge was kind of the itch, that kind of remained behind the analytical problem. And you combine that with the nursing crisis that started with the retirement problem before pre-pandemic, where the average nurse was over 50 years old. We were losing our bedside talent, and then the pandemic expedited things. And so currently, hospitals are in a staffing crunch when it comes to nurses, and the need for some type of technology to point the direction as to who needs better training to dramatically improve outcomes has never been bigger. And so CareFX is a service that we offer as a monthly software as a service that helps point the way. And of course, we staff our company with clinical experts who understand the way that bedside care is performed and can translate advanced analytics into what do I do differently.
That's great in terms of me being a patient, just to hear that you can zero in on somebody who just, like a coach with a team, might need some coaching in an area. Now, this also applies to opioids, the use of opioids, correct? Now, it's a hot topic, right, nationally. Tell us how this might work.
Yeah, so opioids, for a decade or so, we've been talking about the overuse in society in general and the abuse potential of opioids. And I think people are pretty well aware of that. We're just starting to understand, however, how inpatient opioid use, specifically excess inpatient opioid use, affects patients while they're in the hospital and then after they leave. For example, this really surprised me. Just recently, there was a study that showed that if you fully wean someone from opioids by the last day of their hospitalization, and they go the last 24 hours of their hospitalization without opioids, at 90 days post-discharge, they're half as likely to still be on opioids, meaning that the care plan you put in place and how you handle opioids as an inpatient affects patients out 90 days after they leave. And that continued excess use as an outpatient has tremendous effects on that patient and their risk for other diseases, addiction, and it goes on and on. And so we developed this technology that allows us to understand how individuals contribute to individual caregivers contribute to individual patient outcomes. And then it becomes a question of which problem do you want to tackle? Which problem in the hospital right now is most dangerous and most modifiable? Currently, opioid stewardship programs in hospitals are focused mostly on physicians and prescribing. But if you look at the data, you find that over 80% of prescriptions or of medications dispensed in the hospital are done so in a way that we call PRN, or as needed. That means that the nurse is in control of that medication, not the physician. The physician is not the one deciding that another dose is needed, it's the nurse. 95+% of the time, that is exactly what you need. I mean, there's no one better positioned to provide empathetic pain relief and care delivery than the nurse. They are the center of bedside care. However, in about 5% of the cases, there's overtreatment, whether it be due to education not being in sync with the way pain should be assessed in an objective and reproducible way. Could be a new nurse, could be someone who's just out of school. Maybe their trainer, tended to overtreat as well. Maybe they were trained in a different environment with a different set of patients. And so there can be an education component. There can also be a secondary gain component. Sometimes they may not even realize this. Previously, although recently this has changed, surveys given to patients were asked explicitly, about pain. And so unit managers and educators were sensitive about making sure that pain was always addressed. And so there was a lot of positive incentive to give the medication, but not a lot of kind of, hold on, let's wean incentives. Because if you give the maximum amount of PRN opioids to your patient, they will sleep at night. They will not ring the call button. And so that's relatively less common event, but it happens. And so there needs to be a targeted way to understand what is excess. That's a hard question and kind of goes back to my earlier discussion of, how do you understand an individual's risk in terms of the context of care? And the way that we do it is we look at context of care adjusted peer comparisons on the same patients. And so we're adjusting for all of these things, and we're able to understand how you as an individual are different from your peers in the use of opioids. And we can even look at things like after you leave the hospital, how do your colleagues, treat pain, which would show us did you overtreat or undertreat. So we're able to find overtreatment and educate those who need it. And the outcomes that we see from a hospital that employed this is astonishing. So we focused on less than 5% of the nursing staff who received opioid training, pain assessment training, and they knew that their unit manager was concerned about their use. We saw over 20% decrease in overall opioids, even though we only interviewed and talked to 5% of the nurses. And what's more, after 6 months, we were able to see statistically significant reductions in ER revisits and readmissions, almost 40%. Decrease. And so, as I said, opioids are a big problem in healthcare. It's very difficult to find the individuals who really need the training. There's a lot of positive results from giving the medication, and not a lot of reasonable, objective pressure to make sure that it's appropriate.
Looking at care effects and thinking about everything you've described, the different components of it, it's obviously a helpful communication tool. There's an educational component when you think about a nurse manager and the staff, and a risk management component, right? In thinking about opioid use. And I guess too, there's really kind of a quality piece of it. And when you think about payers moving towards, reimbursement based on quality, how does care effects kind of factor into looking at quality of care given by, in this case, clinical, but non-physician personnel?
Yeah, great question. And there obviously quality and pay for performance has been around for a long time. I think that the thing that will make payers most interested in care effects and the topic of opioids among inpatients in general is the effect that it has outside of inpatient. So in the hospital, we call complications from opioids opioid-related adverse drug events. They affect about 7.5% of patients who get opioids in the hospital. That's over 50% of patients get opioids. So about 4.5% of patients who walk in the door of the hospital will have an opioid-related adverse drug event. That's a lot. That's 1 in 20. They cost about $7,000 each in terms of extending the length of stay. But beyond the $7,000 for inpatient care, it's the effects on outpatient care that employer groups and payers are going to be very interested in. If you're an employer, you certainly don't want your employees coming out, with an opioid burden. And you don't want the extra, care that's required to care for someone who got too much or wasn't effectively weaned. And so, the type of targeted, focused opioid stewardship that our analytic service can provide is packs a big punch and limits the amount of time that the nurse educator needs to spend because we can focus on 5% and get a disproportionate effect. Because as experienced bedside nurses are in limited supply, experienced nurse educators are in greater supply. And so this is making the best of a really limited resource to improve patient outcomes, improve patient safety and nurse safety as well.
More and more on our podcast, it seems like the next topic continues to come up, and that is artificial intelligence, AI. So hearing you say you are at the forefront of it, decades ago is amazing. I'm curious to know what you think now, because it feels like we're just now on the frontier, even though you were, way back then.
Thank you for that decades ago, Heather. I appreciate it.
96, I guess. Was that 96?
It has been a really long time. Thank you. Yeah, absolutely. We were working on this stuff in the early 90s in a way that would seem primitive today. If you had asked my friends who are computer scientists, some of whom have their PhD in AI a year ago, would we be where we are now? They would not even comprehend what ChatGPT is able to do. So there's been a major leap forward in terms of the ability of these systems to better integrate with the way we communicate and communicate back. It's astounding. I think, my crystal ball says it's going to become as ubiquitous as .com in 1999 to continue the 90s references. I mean, it's going to be everywhere and in everything. But there are several really big challenges that we need to look at really hard, especially when we talk about healthcare, and even more so when you talk about quality of care. Because as I said, improving the quality of care requires a human being to take the data that you're presenting to them, understand it, have faith in it, and then act on it. And the problem with AR systems right now, a couple of really big ones. One is the hallucination problem. I don't know if you've played with ChatGPT or used it in a professional way, but when you really need it to draw the appropriate references scientifically, it often misses and doesn't know exactly how it knows things. So there's a problem in the scientists call it interpretability. So you have the inputs that come in the top, and then there are these neuron kind of built layers, and then there's an output. I think it's a lot like Plinko. If you watch The Price is Right, the input are the discs at the top. You guys, we're doing 90
Yes.
frequencies.
Yes, I'm with you. I'm the oldest here, so I'm completely with you.
It's my favorite game.
So we're gonna do AI by Bob Barker. So the disk comes in the top. That's the input, right? And it goes through these layers of mathematics, of linear algebra, and along the way, that signal gets transformed into some type of answer. It goes into some bin at the bottom. Hopefully, the $10,000 prize or the car, right? But humans are feeding the disks, and so the human beings are feeding it data to train on, right? So that's not artificial. That's humans training it. And so that leads to potential for bias. And then we're also labeling the categories of whether the output was good or bad. That's another opportunity for potential bias. And so the interpretability problem is that we don't understand how it gets there. And so you've got bias on both, potential on both ends, and you've got an unintelligible, uninterpretable set of numbers in the middle that we can't really work backwards to understand why did it make this decision. And so, in my focus, which is improving quality of care and performance, you can't go to someone with a black box answer and say, the AI sent me, I'm here to talk to you about your nursing care. Well, that's a very personal, very, professionally threatening thing to say. You better be able to show me how you got from point A to point B and all the way back and trace everything. And so AI cannot do that. There are scientists working on that interpretability problem, but so far it's beyond our ability to understand. So it's the assembly of these systems are modeled after biology, and it's kind of like watching your 3-year-old and saying, how did they learn to do that? And I think we're at that moment right now in AI, and it's going to take quite a bit of additional work until it's ready for people to accept in certain roles, especially in healthcare and especially in quality.
Well, I hope others are as cautious and maybe as intentional about it as you are, because those of us relying on care from, educated professionals, I want them to have the best tools possible. I just want the tool to be right. And so if it's AI, great. If it's right and good, but if not, then let's wait, I think. Well, to be continued, because you will probably come up with some other idea that we're going to have you back on the pulse with.
There is a tremendous amount of opportunity on this particular issue. As I said, the problem that we solve uniquely is very challenging, and that's understanding how an individual contributes to patient outcomes is a very hard problem to solve. AI does not solve it because there are kind of some fundamental missing data problems associated with it. And so we solve that uniquely. And then the service aspect of what we do allows for a rare quantity, the experienced nurse educator, to be used much more efficiently and much more powerfully on an important outcome. So, yeah, I hope to come back and talk about the 100 hospital milestone that we've passed.
Well, we will have you back when you do that, and I'm sure that you will, given your track record. Dr. Pat Hymel, thank you so much for joining us. Physician, entrepreneur, CEO, and co-founder of Indicator Sciences. It's been a pleasure to have you today.
Thank you, Heather. I appreciate the opportunity.
And for those of you who joined us, we hope you learned a little bit more about the advancements in healthcare. We are always open to your ideas for guests on Taking the Pulse, so be sure to share with us your thoughts on that. And we look forward to seeing you next time, right here on Taking the Pulse, a healthcare and life sciences video podcast.